All right, hi everybody. So what we're talking about is where I start my corrective exercise strategies or my rehab protocol. And what we have is called a 4x4 matrix. 4 and 4, 4 body positions, 4 types of resistance. So the first body position is non-weight bearing. So somebody comes in with a shoulder complaint and I've done my joint manipulation, my soft tissue manipulation. I've used some sort of kinesiology tape to support the structure that I've just treated. Now I've got to give them some sort of resistance. And so the way that I start things off is in this non-weight bearing position, because we take gravity out of the equation, and then we can start to implement some resistance as they get better in it or improve their range of motion. So the first body position is non-weight bearing. And at first we don't use any resistance. Pattern assistance means that they need help with the exercise. Pattern assistance can be me taking, let's say for example, a shoulder. Let's say somebody's having difficulty, they are showing signs of impingement. So they're having pain with a painful arc. They have pain with Hawkins-Kennedy, resisted extension or external rotation, resisted internal rotation, all painful. So I do my treatment, I go and I retest pain-free range of motion. Now I want to groove that pattern with an isolated exercise. What I would do is put them on their back, non-weight bearing. Then I would have them do no resistance, and they're just going to take their hand like this, and they're going to start bringing this overhead. Now they might still get a little bit of pinching during that motion, even on their back. So what I would have them do, I would have them use their other hand, press their hand into the table, which engages their core, and now they can usually get through that range of motion as long as their mechanics are right, keeping the shoulder down and back and cueing them properly. Another way to pattern assist, so this is pattern assistance if we're engaging the core, they're not just taking themselves through the range of motion. Another type of pattern assist is me as a clinician, pattern assisting them through the motion. The third type of pattern assist that I use is tape. So I use kinesiology tape on the shoulder to decrease the pain or to increase the space, subacromial space. Then they can use that range of motion, but without the tape they couldn't. So that's a pattern assistance, it's helping the pattern. The second time they come in, let's say they've been doing this for 3 or 4 days, and now you're ready to progress them. The next step is just no resistance. Could be the same exercise, could be still these floor angels, but we take pattern assistance away. They can just do it on their own, so that's a progression. The next step would be resistance with pattern assistance. So I might use tape again as the pattern assistance, or I might help them, but I'm going to add some sort of load. So in the case of the wall angel, what I might do is add a TheraBand, tie one around their foot, probably on the opposite side, have them hold it, open palm, and then bring their arm overhead. So they're still grooving the same pattern, the pattern that was painful previous to my treatment. The last one is I take the pattern assistance away, and now we just have resistance. This process can take me a day. Like I might be able to progress somebody, but I always start at a 1x1 because I'm not sure where that person is, and I don't want to skip steps. I could start them at a 1x2, at 1x3, 1x4. You can start them anywhere that's appropriate. If an exercise is too easy, you can always progress them. Like let's say I have them doing an exercise and they have zero pain, and I think that's a good starting point. I try to do the next step, and it's causing pain or there's dysfunction in the movement pattern. I would just regress them one little bit. Another step too, what I love about this is that if somebody, let's say I've treated somebody a couple times and they're coming in now and they're at level 3, but they have a flare-up. They start to have more global pain or inflammation. Then I might say, well, I think those exercises are too intense. What I'm going to do is regress you back to the step right before. So there's small steps in between here that allow us to systematically progress somebody through their corrective strategies. The other thing that I love about this is that if I'm not here and one of my associates sees my patients, what they can do is they can see in my chart notes where and what exercises I've been given. They'll know what framework that is, and then they can progress them as long as they haven't had a flare-up. So it's really valuable to have a systematic way in order to get your patients and your athletes getting into that progressive resistance. They go through all this. It might take a week, might take 2 weeks, depends. Post-surgical would take longer, clearly. Now they go to the next body position, which is a quadruped. Quadruped on all fours, hands and knees. And then they would go 2 by 1, 2 by 2, 2 by 3, 2 by 4. That might, again, take a week or two. Once they've been through that, then they're going to go to half kneeling. And a half kneeling position is basically a lunge. And what you're doing is you're challenging the core to work with the hip, and it's really challenging stability. So when we do it this way, what we're trying to do is really try to increase the proprioception. You're using more of the movers than you are really of the stabilizers, because now you're starting to hit more of gravity-based exercise. Remember, in gravity-based exercise, just being upright requires our stabilizers, or really our posture muscles, to work at about 30% of their mean circumference, MVC. Fourthly, we have standing. And here's where we kind of get people going into their normal, and you would still do a 4 by 1, 4 by 2, 4 by 3, 4 by 4, but just in a standing posture. We're going to talk about this more later, but up to about a 1 by 4 is really working motor control. We're not really trying to change circumferential measurement of a muscle, hypertrophy. We're not doing that really. What we're trying to just do is get a better brain connection. Because what we know is that when we have an injury, we lose proprioception, and that area no longer works as well. So I like to do something called isolated exercise. So let's say I have that shoulder injury. I might do some sort of rotator cuff, internal, external rotation. There's a lot of different varieties that you can do. But then, I think what's really, really important is to do a whole body exercise in conjunction. So I always give isolation and integration, because the brain needs to be able to communicate well with that piece. And it's not just strength, it's not just stability. A lot of times it's about timing, it's about proprioception. There's other things in there that are very important to function. I hope this helps. If you have any questions, shoot me an email. And hopefully you'll be able to utilize this information not just with your clients and your patients, but also in your case report. You're going to have to do a little researching, a little hunting to see some of these exercises. I'm going to give you a little clue. Go to functionalmovement.com. I took this from the book Movement by Gray Cook, and I just kind of tweaked it into a format that's a little easier to understand. All right. Thanks, you guys.